Welcome back to Beyond Survival, the ARDS Alliance podcast, where we dive deep into stories that inspire, educate, and empower. I am your host, Paula Blonsky, president of the ARDS Alliance, and today I'm honored to be joined by Dr. Brian Peach, a critical care nurse scientist and researcher whose work focuses on ARDS survivors and post-intensive care syndrome, or PICS. His research has brought greater attention to the long-term challenges patients face after leaving the ICU, physically, emotionally, and cognitively, and what healthcare teams can do to improve quality of life. In this conversation, we'll explore his journey into critical care research, dive into his latest findings on ARDS and PICS, and talk about what the future holds for survivors, families, and providers. Welcome, Brian.
Thank you so much. And let me just say what an honor it is to be on your podcast. As you know, I'm a great admirer of the work you and the ARDS Alliance have done on behalf of those that live with the nightmare that is ARDS. So just such an honor to be a part of this conversation.
Wow, thank you so much, Brian. So can you share a little bit about your background and what led you to focus your research on ARDS and critical care?
Sure. Yeah. So I've been a nurse for 20 years. 19 of them were in practice. Most of that time was spent in intensive care units. I worked for 9 years at the Hospital University of Pennsylvania in Philadelphia, 5 years at UF Health Shands Hospital in Gainesville, and then 5 years at Orlando Regional Medical Center. And then for the last 7 years, I've been at the University of Central Florida, which you'll hear me refer to as UCF.
Okay.
So I'm an associate professor here, and the focus of my research, as you said, is post-intensive care syndrome, and I've had some projects specific to ARDS survivors. And so if your audience is unfamiliar with the term post-intensive care syndrome, it refers to new or worsening impairments in physical, cognitive, or mental health status arising after critical illness and persisting beyond acute care hospitalization. So there are survivors that for months to years afterward have these long-term issues that they're living with. And I know we'll speak more about that. But in terms of your second part of the question of what led me to focus on ARDS and critical care, it was just my experience caring for so many patients with ARDS over the years at the 3 hospitals I mentioned. Most of them had ARDS triggered by sepsis or smoke inhalation. And they were usually the sickest patients I took care of in the ICU. They were on ventilators, they were on analgesic and sedative medications. They were oftentimes put on paralyzing medication to take away their work of breathing. So paralyze their chest so that the ventilator could do the work.
Mm-hmm.
And we oftentimes had to use proning, where we would flip them over to help with their oxygen issues, or what's known as extracorporeal membrane oxygenation, also known as ECMO therapy, to help oxygenate their body. And so, we saw an increased number of patients with ARDS during the H1N1 swine flu pandemic of 2009, and of course the COVID pandemic. And what disturbed me was that I saw young people with no past medical history that were coming in extremely critically ill. And if you were over 50 with other medical conditions, there was an extremely high likelihood that you weren't going to leave the hospital alive. So that's what really interested me in ARDS. And then from a post-intensive care syndrome standpoint, years later, I was attending a conference and learned about some of the long-term struggles that survivors were living with. And, I don't think that there's any nurse that is in this caring profession that would want survivors to have a poor quality of life after, we save their lives. So that for me was very motivating to get into this line of work.
Okay, great. And from your perspective, how has the field of critical care research evolved over the last decade? That's a big question.
Yeah. Did you say how research has evolved or practice?
Yeah, research.
Research.
Mm-hmm.
Yeah. So many ways. We're constantly looking for better medications and procedures to be able to help people. I think there's been a lot of work in terms of those sorts of things. But I think I think one of the biggest things we've seen is there is a recognition that delirium that many survivors live with, or I'm sorry, delirium that they experience in the hospital is not normal.
Right.
And so there's been quite a bit of work, to address how can we prevent delirium, how can we better treat delirium, and then also recognizing that patients who develop these long-term issues, these cognition issues and mental health issues, physical issues, that they have a high likelihood of having delirium in the hospital. So that seems to be a risk factor. And so I think there's a recognition that we can do things better. And much of the research has been targeted towards reducing delirium and improving outcomes for patients. So I think that's been a welcome change in research over the last few years.
Agreed, agreed. Our last guest on the show was Kaylee Dayton, and that's her whole podcast and research as well is reducing sedation, which would ultimately reduce delirium and hopefully PICS and so many things, right?
Yes.
So yeah, I agree with that for sure.
I'm a big admirer of her work.
Me
She
too.
has some, if your listeners didn't listen to that podcast, be a great idea to do so. She is a big proponent of awake and walking ICUs, and so really trying to limit the use of sedation. We used to want to snow everyone. That was the term we would use. Knock them out cold, and I think nurses, we want the best for people, and the thought was that if we knock them out cold, that they won't remember their ICU admission. But we're recognizing now that we sometimes prolong their ICU admission. We prolong their time on the ventilator, and they develop these long-term, PTSD and other issues from being too heavy-handed with sedation. So I think she's doing a very important thing in raising awareness about the dangers of being heavy-handed with sedation, and also educating people that we can do things better. So strongly recommend listening to her podcast, Walking Home from the ICU.
Yeah, it's amazing. And that's a new term I haven't heard, snow. Yeah, I haven't heard that before.
Yeah.
So, okay, we talked a little bit about PICS and the definition of PICS. For those that might not be familiar, can you explain what ARDS is and why it's so serious?
Sure. Yeah. So ARDS is a condition where patients have a flood of inflammation to their lungs, to both lungs. And it can be triggered by a number of different things: infection, infections like pneumonia, aspiration of things going down the wrong tube into their lungs. So, that could be they're vomiting and that vomit goes into their lungs, sepsis, smoke inhalation, drowning, trauma, and then there's some other causes as well, but those are kind of some of the most common reasons.
Yeah.
And so they have this massive flood of inflammation to their lungs, and that inflammation triggers blood vessels in the lungs to become very porous. And so water begins to spill into the lungs. We call that pulmonary edema. And so patients are essentially drowning in this fluid, and it impacts their ability of their lungs to be able to exchange oxygen and carbon dioxide. And so these patients become extremely sick in a very short period of time. All your organs need oxygen. Your body needs to get rid of carbon dioxide as a waste product, or the blood becomes too acidic. And so patients with ARDS go into multi-organ failure. Oftentimes their kidneys, their brain, their heart, the liver, and other organs are affected. And then ultimately, that persistent inflammation can lead to changes in the lung tissue. And so within a couple of weeks, the lungs oftentimes become scarred. And those who do survive often have long-term lung issues related to that scarring, those scarring changes within their lungs.
Right. Thank you for that. It's always interesting to me to see. Obviously, I'm with the ARDS Alliance, so I know what ARDS is, but I always ask for different definitions because sometimes it's very hard to explain it in simple terms because most people haven't heard of it, which we're trying to change. So thank you for that.
Yes, absolutely.
So what do you think is the biggest misconception patient families or even clinicians might have about ARDS?
Yeah, that's a good question. I think some people confuse ARDS with pneumonia. And so pneumonia can be its own condition, or it can trigger ARDS. And again, with ARDS, you have this huge inflammatory response and you have inflammation and fluid in both lungs.
Right.
And key to the definition is that that fluid in the lungs is not related to heart failure. So heart failure can cause fluid accumulation in the lungs, but this is a different sort of mechanism that is occurring. And then I think the biggest misconception clinicians have is these people return back to, they may think that these people return back to normal after we save their lives. If you're working in an ICU, you don't see these people after they leave. And so it's important that clinicians recognize that these people are not okay. Not only are they physically affected by being in bed for days to weeks, but they also have new cognitive and mental health issues. They struggle because they lost days to weeks of their lives, and they have to try to reconcile with that. And what did they miss during that time period? Sometimes they missed very important events in their loved ones' lives. Their muscles are severely weakened, and so they oftentimes deal with weakness and fatigue for months, years. Sometimes they never fully recover. They had periods of their illness where their oxygen levels were very low, and so that has implications for their brain function. So I think sometimes as clinicians, we're very narrowly focused on saving their lives, which is absolutely important.
Right.
But we don't realize what can happen after the fact too, happen after the illness. And as I think we'll probably talk about, there are things that we can do to try to both help save their lives, but ultimately also help them have a good quality of life afterwards.
Right, which is just as important. Obviously, saving your life for sure, but quality of life afterward for survivors is very important.
Yeah.
So how do you see ARDS management changing in the coming years, whether through technology, treatments, or awareness?
Yeah, that's an interesting question. I want to start by saying I am not Nostradamus, so I have no way of knowing the future. But I do know that there's research underway to identify biomarkers that would help us predict which patients are at risk for ARDS and to help us identify the condition quicker. There's a lot being done in healthcare right now with artificial intelligence algorithms, and so using them to help us detect conditions like sepsis, which can be a trigger for ARDS and ARDS quicker, and also helping us tailor therapies based on a patient's phenotype. So their phenotype are their personal characteristics. There are ECMO trials going on, and I suspect we may see more usage of that therapy.
Right.
I think there's a lot of work to be done to develop vaccines that prevent the viral infections that can trigger ARDS. I think we're always trying to figure out the best methods to help survivors with or I should say patients rather, with their oxygenation ventilation issues, and also looking at ways to suppress the deadly immune response, that occurs with ARDS. And then from an awareness standpoint, there's a huge knowledge deficit about post-intensive care syndrome. And I actually have a personal goal of making PICS as publicly known as, say, a heart attack or a stroke. The problem is people don't know about it, and our acute care clinicians aren't educating. When I say people, I should say the patients and the family members don't know about it. They're oftentimes not warned to anticipate it. And that's partly because our acute care clinicians aren't aware of these problems. And so they're not educating people. They're not preparing them for what comes after the critical illness.
Right.
Most of our primary care, rehab, and home health agencies are not screening for these new or worsening cognitive and mental health issues. I hear this from survivors all the time when they come in for a primary care appointment after getting out of the ICU. It's oftentimes focused on whether they're having weakness or shortness of breath, whether they're able to take their medications, if they can get themselves dressed. And the physical health issues are absolutely important, but it's important that these other issues not be forgotten, because it's the cognition and the mental health issues that oftentimes impact people's ability to work, earn money for their family, pay their medical bills. It impacts their ability to socialize with their families. So it's very, very important that our clinicians, particularly in ambulatory care settings, learn more about post-intensive care syndrome. And if I had a dollar for every critical illness survivor who's told me their needs are not being met by their primary care providers and by the specialists that they see, I could probably retire right now.
You and me both. Yeah, I think there's so much with ARDS. There's not one therapy that fixes everyone. That's very frustrating. You don't know what to tell the families, right? That reach
Yes,
out and so forth. And if after the ICU and they go home, if it's not being addressed, the PICS is not being addressed, the survivor doesn't know
yes,
what's
right.
wrong, right? And they think it's just them. And so I
Hmm.
agree, we need to increase awareness for PICS for sure, so that people understand that it's real. Um,
Right.
they're not alone,
Yes.
and that, we're working towards fixing that, right? So
Yep.
for sure. So let's talk a little bit about your research, right? So your research has looked closely at ARDS survivors. What are some of the most surprising findings you've uncovered?
Well, I've collected data on what triggers survivors' ICU memories. Well, I should say I've collected data on what their memories are and then what triggers them.
Okay.
So what I found is the vast majority of survivors don't remember what happens before or after they came off the ventilator. Some of them do remember struggling to breathe before they went on the ventilator. They remember conversations with healthcare providers, who were saying it's very important that we put you on a ventilator, and wanting to say, you know, words to their family members and not being able to do so, and that could be very traumatic, especially during the pandemic when many family members weren't allowed in the hospital or on the unit.
Right.
Um, and then some do remember coming off sedation and hallucinating, seeing spiders on the ceilings and seeing hands coming from around a clock trying to grab them. Really crazy graphic things. But what the vast majority of them remember are the vivid, and I'm going to put in quotations, dreams, because there is some data that shows that when people are on sedatives, they're not oftentimes reaching a true dreamlike state, or they're not actually maybe sleeping the way we think of sleeping. Um, but they remember these vivid images that they had under the effects of sedation. And so that could be thinking they were being assaulted, physically assaulted, being sexually assaulted. A lot of them have these dreams where they were on a boat and they were trapped on a boat.
Hmm.
And so, one of the things I found is that ARDS survivors oftentimes misinterpret what is happening to them. So, a
Right.
common one that I've heard is that their urinary catheter is being cleaned and they think they're being sexually assaulted. So, that has been very interesting to hear what ARDS survivors remember from their hospitalization. And then, in terms of triggers, there's all sorts of things from medical TV shows and commercials and movies to seeing and hearing helicopters. We had one survivor who wasn't actually flown on a helicopter, but his ICU bed was right next to a helipad. So he heard that helicopter over and over and over again while he was in the hospital, including while he was under the effects of sedation.
Mm.
And I think it's important that people recognize that just because you're sedated doesn't mean you can't hear things, smell things, uh, feel certain tactile things. Um, and I guess the most surprising thing I heard, and I've heard this from multiple survivors now, is that they were oftentimes triggered by lawnmowers and weed whackers. And I
Really?
thought, I thought, what is it about lawnmowers and weed whackers that would trigger people? Now we know that people with PTSD are oftentimes triggered by loud, sudden sounds.
Right.
So I thought maybe that's what it is. But I was speaking with a survivor, and she said, I was in the hospital for probably about 3 weeks. I think it was 3 weeks. And she said, I was in there, I had sepsis, and I had ARDS, and I had cardiac arrested. And so I'm in the ICU bed under the effects of sedation. And I was in a bed that inflates and deflates. We have these special air mattresses to prevent wounds on patients.
Right.
And she said, imagine that every 15 minutes, I would hear the sound of this bed inflating and deflating or kind of redistributing the air.
Okay.
And she said, that sounds like lawnmowers and weed whackers. So
Wow.
she said, I live in the state of Florida. In the summertime, we sometimes mow our grass twice a week.
Right.
She said, I can't get away from these sounds. It's constantly triggering. And so that's another thing I've learned is that survivors are constantly being triggered by things around them. And so it leads to avoidance behaviors. They try to avoid places where they're going to encounter their triggers.
Right.
And that oftentimes means that they don't leave their house, or they rarely leave their house because they're trying to avoid all these different triggers.
Right. Yeah, I've heard that as well about the boat, and it
Mhm.
is that same bed. It's either the proning bed or the machinery that deflates and inflates. It feels like a boat, right?
Yeah.
Uh,
Yep.
so yeah, I've heard that quite a bit too.
Yep.
So how do you balance the focus between improving survival in the ICU and improving long-term quality of life of survivors? How do you balance that?
Yeah, that's a really tough question. I think we're all trying to find that balance as clinicians and researchers.
Right.
I think our priority has to be doing the things that improve the patient's oxygenation and ventilation of carbon dioxide to save that person's life. And honestly, these patients are so sick that it's hard to do that without a ventilator. And ventilators, by the way, don't fix the lungs.
Right.
They just, buy the patient time so that our medications and other therapies can help with that treating the underlying cause and hopefully that inflammation recedes. I think what some of the things that are important are positioning of the patient. You mentioned Kaylee Dayton earlier. She talks about this a lot. And I think you and I have a mutual friend, Margaret Arnold from earlymobility.com. And so they both talk about how important positioning is of the patient to help them with oxygenation, ventilation. There are now vertical beds that stand patients up.
Hmm.
Now, I've read some of the papers on this, and it certainly seems to help with oxygenation, but it also can drop their blood pressure. So I
Right.
think timing of interventions is probably really important, and recognizing that, maybe we can't use that vertical bed in the first, 24 or 48 hours or whatever.
Right.
But maybe as they progress further on in their course, we start to make the shift from treating their illness to getting them ready to go home. And so I think it's important that we do mobility exercises with patients when they can tolerate doing so from an oxygenation standpoint, instead of just having them lay in bed for days on end and then sending them to a rehab.
Right.
That we can start that rehab process earlier. Again, not when they first come in, but we can start later on as their lung function is improving. They can lose a lot of muscle mass when they're just laying around in bed, and that includes the chest muscles, which are really important for breathing. So we need to start that rehab earlier. And I think when we start patients on ECMO, that machine does the work of oxygenating the blood.
Mhm.
Um, that we have an opportunity now to start ambulating the patient. And early in my career, if a patient was on a ventilator, if they were on ECMO, you did not get that patient up. And we're realizing that by not getting that patient up, that they're going to develop a lot of issues with muscle atrophy. And so we now recognize that you can absolutely ambulate patients that are on a ventilator or who are on ECMO. I know this personally because I've done it. I've ambulated these patients, and that's a hard shift in thinking for clinicians to make who are so used to just letting these people recover in bed. Again, timing is everything. Making that shift when that patient is able to start doing that, and it oftentimes is a lot earlier than I think most clinicians realize.
I agree. And if you keep that mobility going and when they're awake enough to start to communicate, They can't
Yep.
talk because of the vent or the trach at that point, but maybe they could write. But if they're too deconditioned, they can't even move their hands or arms or anything. So,
Absolutely.
yeah, there's
And
so
I think
many good things with early mobility.
And I think also recognizing that we need to be very careful with when we start sedation and if we need to use sedation, which with ARDS patients, I mean, it certainly happens, that we need to help them synchronize with the ventilator. Um, but being careful about what drugs we use, how much of that drug we use, using the amount you need for them to achieve the therapeutic effect, which is the synchronization with the ventilator. Um, but we don't need to completely always knock them out. And so I think that's really important as well.
Agreed. So I'd like to talk more about PICS.
Mhm.
So many survivors experience physical, cognitive, and emotional struggles after leaving the ICU. Can you describe what PICS looks like in the real life? Like, how is it affecting the survivors?
Sure, absolutely. Well, so it's weakness and fatigue, which oftentimes impacts survivors' ability to um, care for others, care for themselves, uh, go to work. Many of them will have mobility issues, or as you raised, they may have weakness in their hands. And so just things like typing on a computer could be very difficult for a survivor. They have trouble with concentration and decision making. Many of them say, I have this recipe that only has 4 or 5 steps, and I have to keep reading it over and over again because of concentration issues. My loved ones want me to make decisions, and I just cannot cognitively make those types of decisions anymore. Things that were very simple for people before. I've had survivors in my research studies who were engineers or accountants. They worked with a lot of numbers, and now all of a sudden, they can't do basic math.
Right.
Um, a lot of them have insomnia related to medical or non-medical nightmares, anxiety attacks, depression, hypervigilance, constantly worried about getting sick again and ending up in the hospital. And so, with that hypervigilance, there's oftentimes an avoidance of family members and friends. They oftentimes will go to the grocery store, or if they, feel confident enough to go to the grocery store, they will go early in the morning or late at night because of a fear of getting sick. And then lastly, I would say avoidance of loud, crowded places like restaurants and movie theaters and theme parks. And it's partly because there are things in those places that can trigger them. The sounds oftentimes are very triggering. The sounds, let's say in a restaurant, of plates,
Right.
um, you know, uh, plates crashing or whatever can trigger them.
Mhm.
Um, but it's also that fear of getting sick again. And so you see a lot of these avoidance behaviors.
For sure. And how does PICS specifically impact ARDS survivors compared to other ICU patients?
Yeah, so there's a lot of crossover between ARDS survivors and other ICU patients, patients with sepsis in particular as well. I think what's different about ARDS survivors is that they tend to be sicker than some other ICU patients. I think ARDS and sepsis is pretty similar. Patients end up in the hospital for oftentimes weeks. They're both oftentimes on a ventilator. And so there's a lot of similarities between those two groups in particular, that they have a higher prevalence of developing post-intensive care syndrome. And, there are some patients who will leave the ICU and they'll get better and they'll get back to their previous normal. I think that's harder for the ARDS survivors to get back to their previous normal. There are some that get better, but they kind of level off and they never get back to their previous normal.
Right.
And then there are some that actually get worse. Their mentation, their cognition, and their mental status get worse with time. And so what I've seen is with many of the ARDS survivors, they're kind of in those last two groups. So they level off, but they never get back to their previous normal, or sometimes they get worse.
Yeah.
And so length of stay, whether someone was on a ventilator or not, those are predictors for developing PICS.
Hmm.
And because the ARDS survivors always have long lengths of stay and are almost pretty much always or just about always on ventilators, they are more likely to develop PICS.
Yeah, for sure. So in your work, how have you seen families play a role in both recovery and in research?
Yeah, that's a great question. So I think families play a very important role in terms of recovery. And in fact, I think they oftentimes, you know, feel burdened to help their loved ones. They absolutely love their the survivors and they want to help them, but it's a lot on them because the survivors oftentimes have a lot of medical appointments and they may need some help getting dressed. They may be dealing with some tough emotions. So family members really shoulder quite a bit of the burden in terms of the recovery. Um, from a research standpoint, I think one of the things we as researchers should do, and I've learned this from other researchers, this is not an original idea, is that we should talk to patients and family members and learn from them. I've learned quite a bit from patients and family members about what their long-term, what that recovery looks like. It's helped generate research questions for me. So I think they play a very important role in that way. And then I think that they can also be pivotal to advocacy work. And you and I are both involved with some national advocacy work, international advocacy work.
Right.
And so I think families play a very important role uh, and patients in terms of raising awareness about PICS and about what it's like to go through an ARDS admission.
Right. And do you have any advice that you would give to families supporting a loved one through ARDS and recovery from PICS?
Yeah, that's a great question. I don't have personal experience as a family member of an ARDS survivor, but I've talked with a lot of survivors, and I think the number one thing I would say that I hear from survivors all the time is their family members say to them, "Why are you unhappy? You should be happy you survived." And it's not just their family members, it's the coworkers and friends and others that say, "You should be happy."
Yeah.
And the ARDS survivors say, "I want to be happy. And I am happy that I survived, but I'm dealing with all these issues, these cognition issues, these, PTSD. And so no matter how much I want to be happy and you want me to be happy, you have to understand that I went through something incredibly traumatic." So I think it's really important for families to try to avoid using that kind of language because these survivors are oftentimes dealing with guilt that sometimes it was, a decision they made that led to ARDS, but more often than not, it wasn't. It was out of their control.
Mhm.
They feel guilty about what they put their family members through. They oftentimes have survivor's guilt that
Mhm.
they survived when other people did not.
Right.
And so I think it's really important for families to recognize that they should avoid that sort of line of thinking and instead, to the best of their ability, be there to support their loved ones and understand that it's going to be a long road of recovery. And then maybe helping connect them with resources that are available to help them recover.
Right. Especially support groups, right?
Yes,
'Cause
absolutely.
I think that helps so much as far as, if you get family members on there from people that didn't make it, they can talk
Hmm.
with the survivors. And,
Yes.
I'm one of them. My sister did not survive ARDS, and survivors say that to me. How can you talk to us? Aren't you mad? Aren't you? Absolutely not. There's something in them. There's a reason they survived, and they're the
Yeah,
key that's gonna someday find a cure, right? And
yep.
so that nobody else has to go through it. So I
I
agree.
certainly hope so.
Yeah,
Yep.
me too. So I'm sure this is a yes, but have you come across any particularly inspiring patient stories that have shaped the way you approach your research?
Yes. Well, actually, the reason I'm even in this line of research was I was at a conference years ago in Indianapolis, I believe, and I saw somebody that was presenting on PICS, and it was a notable researcher. And I remember being impacted by the researchers' words in their presentation, but they had a family member, I'm sorry, they had a patient come with them, and I was just totally blown away hearing from the patient. And so I couldn't tell you the patient's name. I probably couldn't even tell you what the patient was admitted with, but I do remember how he made me feel when he told me his story. And so now, whenever I go to speak in hospitals or speak at conferences, whenever I can, I try to bring family members and patients with me
Yep.
so that other people can hear their stories, because I remember how that impacted me. And I've learned from others that sometimes as researchers we put up our sort of professional wall, and we're supposed to do our research and not really build relationships with those that we are doing our research with. But I've learned from others that it's really important that we pull these patients and family members in and learn from them, and that it's okay to build relationships with them, particularly after they finish with our research.
Mhm.
Um, so I've been inspired by, and I know you know some of these people, a guy named Spencer Freeman. He was not part of my research, but he's a survivor and survived pancreatitis. And I've been inspired by my friends Angela Leggett and Cheryl Thompson, who are both cardiac arrest survivors. And they've told me I know I can share information about them. So, um, absolutely, there are people who've inspired me to do this work, and honestly, they're some of the biggest motivators for why I continue to do this work.
Agreed. Same. Nothing more powerful than the patient voice, right?
Yep.
Okay, so looking forward, what do you think is the biggest opportunities for improving outcomes in ARDS and PICS survivors?
Yeah, I think preventative care is going to be really important, figuring out ways that we can prevent ARDS from developing. And so whether that's through vaccines or, if there's some sort of medication that can be developed, that when a person is showing signs of respiratory distress, that we can intervene early and maybe block that huge inflammatory response would be very important. Um, and I think if we can better treat ARDS, we can probably reduce the risk of PICS developing as well. So, I think there's lots of opportunities there. I also think within the acute care setting, as I've kind of highlighted a little bit, I think we can do things better to both reduce the risk for PICS and then educate people better so that they are more prepared for it after they leave the hospital. So I think there's lots of opportunities there.
For sure. What collaborations or cross-disciplinary work do you think are most needed in this space?
Yeah, great question. Um, I think that, so I'm a nurse researcher.
Mhm.
I work with other researchers who are physicians, psychologists, pharmacists, um, other nurse researchers. So I think that we all approach things in a little bit different way with a very different perspective. I'm currently working on a project right now with people from Vanderbilt University and Rush University and the Medical University of South Carolina and somebody from the University of Virginia Medical Center and UCF. And hopefully I didn't leave anyone off. But this is a multidisciplinary project. And so I think that's very important in terms of figuring out how we can better treat ICU delirium and post-intensive care syndrome. Um, I think there's opportunities to look at how we can better educate across the different disciplines.
Right.
So I think there's a lot of cross-disciplinary work. And then the other piece I would highlight too is again pulling in patients and family members. They have such a unique perspective,
Mhm.
and I've seen some papers that have been published with patients and family members. And I think that we can and we should do that as researchers. We have a lot to learn from them.
Absolutely. How do you know that your work is going to be meaningful if you don't reach out to those that need it, right?
Yes,
I agree.
absolutely.
Um,
I'll just add too that there is something called PCORI,
yeah.
which is a type of grant where they really encourage these formations of these relationships between researchers and the community. And I think that's such a great model and something that we really need to get in the habit of adopting. And it's not just designing the study and then saying, hey, what do you think? It's having them involved in every step of the process. Because sometimes we are blind as researchers to some issues with the way we've designed a study or our different methods, and they can help shed light on that. So, that's just one particular mechanism in terms of fostering that relationship.
Yeah, that's amazing. So if you could change one thing about ARDS and PICS, how they're recognized or treated today, what would that be?
Uh, well, I certainly would love for ARDS to be recognized quicker and for us to be able to address it. Uh, I guess I spend more time thinking about PICS. And so if there's one thing that I wish would be better, it's what's happening in the outpatient setting. I think that primary care providers, rehab providers, and home health can be do a much better job of recognizing that these critical illness survivors have these long-term issues. And what I hear from survivors all the time is they are not screened for many of the issues that they develop. They feel like when they raise those issues that they're told, oh, you'll just give it a little bit of time and these issues will resolve.
Right.
And a year passes and 2 years passes and they're not better. They're still dealing with PTSD. They're still having anxiety attacks. They're still dealing with depression. So there's a lot of false promises being given in those settings. Um, and then I've heard survivors who have been told, you can't develop PTSD from an ICU admission. And as one of the survivors said, well, I remember my tracheostomy falling out. You don't think that would be traumatic?
It's all
Um,
true.
yeah. And then there are others that, they have these very vivid dreams. And, I think most outpatient providers at this point don't recognize that these are issues. And so I'm doing a lot of work from a publication standpoint, presentations, and also through some advocacy efforts. So things like the Walk for PICS.
Mhm.
We are holding a walk in Orlando, and I would encourage any of your listeners to go on the Walk for PICS website.
Mhm.
So we're trying to raise awareness with the public, but also specifically with healthcare providers, saying, first of all, you need to read up about post-intensive care syndrome if you're not already doing that. And then secondly, make some changes in your practice so that you are better meeting the needs of these ARDS survivors and of these other critical illness survivors.
Yes. Yes. Walk for PICS next weekend. I'm actually participating in Nashville. So
Oh, terrific.
yes,
We
yes.
need to get you down to Orlando one of these years.
Yeah, for sure. Maybe next year. We'll see.
Yep.
So how do people get involved in your research, Brian?
That's a great question. So I have, first of all, they can always email me at Brian, Brian, Peach, Peach, at ucf.edu.
Okay.
I have a work Facebook page. I also have a work Twitter page. So I periodically will post flyers. I also post flyers and survivorship pages as well. So if you see any of my flyers, please send me an email and let's talk. And you may qualify for one of the research studies. So lots of opportunities there. I have an ongoing study with ARDS survivors,
Mhm.
and then I have some other studies that are in various stages, some that are upcoming that will be with multiple different types of critical illness survivors. So yes, I'd love for people to reach out to me that way.
Yeah, and they can also get your information through the ARDS Alliance too. So
Yes.
we'll
Yep.
make sure we get anybody over there that is interested for sure.
I appreciate that.
Um, so Brian, I want to thank you for being on our podcast today. Thank you for all your work for ARDS and PICS. Really enjoyed our conversation, and I look forward to seeing more of your work in the future.
Thank you so much. I appreciate the opportunity. And I just want to add too that I know that ARDS survivors and their families often feel hopeless, that things are never going to improve. But I just want you to know that there are a lot of us who are involved in research and advocacy work who really care and are doing a number of different things to try to improve outcomes for you. So I just hope that you will keep that hope that better days are ahead.
Yeah. Well, thank you, Brian. Thank you again for all your work and everything you're doing for survivors. The community really appreciates it.
Thank you so much. I'm just happy to work in this space.
Thank you.